Thank you to Dr. Dat and all the VVI's committee. It's really my honor and pleasure to be here and see the conference go very, very well during couple of years. Okay, so would you please bring my presentation here? Thank you. So my talk today gonna be about the update in management of uveitis. As you just heard about the uveitis, it connects all of the ophthalmology together from the front to the back. And you have heard about the 5 mistakes that we should avoid. And how about the management that we have? This is my financial disclosure. This is quite aligned throughout the uveitis work. Okay? So the first one, we look deeper into the clinical marker of the anterior segment. The most common biomarker that we use is the visual acuity, right? But actually, beyond the cerebral microscope, we also need to look a little bit deeper into the biomarker. If you see here, this is the easy way that we can differentiate things apart. This is the KP. If you just say it's the KP, actually it's not. It can be different. Can you guess which one is with the pathology that it causes? It can be this. You can see like the standard KP in terms of viral. You can see the bizarre KP in the case of lymphoma. The medium-sized KP can be infection, toxoplasmosis per se. The CMV is very specific. If you see the coil-shaped KP, they're really looking for the CMV anterior uveitis, and the diffuse KP and the granulomatous KP in weakhead and sarcoidosis. But sometimes you need to use another technique to look at the eye. This is the eye that look with lethal illumination, and you can see it's quite of time illumination defect there. Of course, it can be viral, but one thing that people usually miss is here. If you look at the UVM in this case have the UGH within the lens is touched and lapping the iris for the whole day. That's why the patient have the uveitis. And we're going to talk about it later in the afternoon section. Let's see in our uveitis work. We are more and more now not diagnosis like the idiopathic uveitis, because we really look into the biomarker and looking for the causes of it. Of course, the anterior uveitis is the most common one, and if you look at there, the idiopathic is about half of the idiopathic. But after we look deeper into the biomarker, you see the idiopathic 40% is the chronic post-op inflammation in this day. Okay. Another one is the IOP. Some people say, "Oh, we are retinal doctor, we are the uveitis doctor, and let the IOP for the glaucoma doctor," which is not real. Okay. The IOP is also very important to evaluate. If you look at here, in the main treatment of uveitis, we use the steroid treatment. And we have to understand that our cornea have 2 lobe. One is the hydrophobic and one is the hydrophilic. And not all steroids make the same job. Okay? If you look at here, this is the steroid that we use currently now. If you treat the anterior uveitis, the soft steroids such as fluoroquinolone or the Lotimax per se is not proper to treat anterior uveitis because it stays only on the surface of the eye. But in some cases of anterior uveitis, you might need stalker. Not just the stalker, but they have to penetrate through the corneal epithelium and the corneal stoma as well. So use the proper steroid for the proper diseases. Okay? And this is the one very important. This is our patient in our clinic. You see how good of them to put the eye drop in. Some people, they put the eye drop in and they use the eyelash just to wipe the eye drop into the eye. So it's very important to teach our patients to use the eye drop correctly, not just order the eye drop and hope they can use it correctly. So please stop and teach them how to use the eye drop properly. So every drop counts. Okay? Another one is when we're talking about the viral association anterior uveitis, in our region it's very common for the CMV anterior uveitis, and we need to understand that the viral associated is different. The CMV actually is not respond well with acyclovir or with phalangocyclovir. It's respond for the valacyclovir. Sorry, it's not respond for Valtech or Famvir, but it's respond to valacyclovir. Okay, because of the thing of the CMV is in the beta herpetic variety, is not in the alpha like the simplex stuff. And this is another one that become more common now. We have the medication that called lock inhibitor, like sodium per se, that really work well with the endothelium diseases. And we all know the CMV anterior devices have the effect on the corneal endothelium. But right now it's still off-label use, but we are on the way under investigation using of the like sodium in the case of CMV endothelitis. And we hope the result gonna come back soon in the near future. Another one about CMV is we already have the staccato study with our colleague in the US, our colleague in the Taiwan, and we hope to have our colleague in Vietnam soon in the future. And we already published this about the CMV anterior devices and the viral load inside of the anterior chamber that respond differently between the oral treatment and the topical encyclopedia. Interestingly, if we look into our data, you're going to see the IOP is really, really different in the CMV anterior uveitis cases. Can we look a little bit deeper into this and say what is really the cause? If we look at here, this is the difference that we use now. Right now we have the equipment that can measure the IOP even at home. Okay? Same as in Vietnam, in Thailand, the cost always challenging. They cannot afford to buy the machine. But what we do now, we have the machine and we let them borrow for a couple weeks. And with the couple weeks that they borrow, we get a lot of diurnal data back. And that helps us to manage the patient. Because of the steroid we use can cause increased IOP, and the CMV anterior uveitis itself can cause increased IOP too. So we have to differentiate that out. This is the study that we did in Chulalongkorn University. We used 24-hour IOP monitoring using the iCare Home tool to measure the active anterior uveitis. And this is the data that the prelim data that we have. You're gonna see it's very different throughout the patient. Of course, the anterior uveitis is not the same. The viral anterior uveitis, the HLA-B27 is different. But in general, patients have individual diurnal. It's not like the normal people or the glaucoma people that have the diurnal and the IOP go very high in the early morning. So for the conclusion for our study, what we find, if we find significant difference in the IOP fluctuation in the case of the anterior uveitis patient, it means that the 1 point of the IOP at the office hour may be not enough to identify the uveitis activity and the glaucoma progression. And no significant difference between mean true IOP and peak IOP. What we find differentiate during the day is important. Okay? Furthermore, the initial IOP predict the use of the anti-glaucoma medication is non-surprise. And diurnal IOP patterns highlight the importance of the home monitoring IOP. Let's go to another promising diagnosis in uveitis. We all know use the culture, we're familiar with the PCR, but what we have now, we have the thing called metagenomic deep sequencing that use the whole genome and we differentiate whole genome out from the pathogen genome. Okay? We do the study with our colleague in the US, Proctor Foundation in San Francisco. It's called Lotus study. The aim is to international surveillance of pathogen causing uveitis, and also another specific aim to categorize host gene expression profile in infectious uveitis. And actually, with this collaboration, we have so many sites around the world, and we hope to have the site from Vietnam soon in the future. Okay, and we have 2 sites in Thailand here. Okay, one thing. Just you cannot say something doesn't mean it's not there. So with binaural technology, not just OVDI, not just only the slam that we need, but we need to look a little bit deeper into the imaging. Multimodal imaging is a biomarker to diagnose and manage of uveitis. You're gonna have the wonderful talk with Professor Yu later, but I would like to introduce you about this one. With the imaging is different. We have multimodal imaging, we have outer wide field, but it's different in terms of the matching. So think which one is to match your practice. Okay, if you in the small practice, maybe multimodal imaging in all in one in the one machine might match. But if you are in the big center and have a lot of people, you might need to separate it out to not obstruct the flow of treatment. Okay, this is the case. Let's say 38-year-old Thai lady with photopsia, headache, blurred vision on the right eye. But actually, when she said blurred vision, the vision is 20/20 in both eyes. If you look at it, you may say, oh, it's nothing there, maybe just a headache. But if you look carefully in detail, you're gonna see here, they have some subretinal white lesion there. And with the multimodal imaging, when we do the OCT there, we see subretinal infusion and a little bit of hyper reflectively dot just O line of the lesion, which meant to be the vitreous cells. Okay? And if you look at the optic nerve on the right hand side, you see very subtle yellow lesion here. We unmask what we cannot see. So when we do the test come out, patient have the HIV, very low CD4 count. It's made up thinking about the infection. And when we work out with the FA, you see some leakage, very minimal from the disc. You see abnormal hypofluorescence throughout left and right eye. When we look deeper into the ICT, we clearly see that the pathology is not just on the retina, but it's also in the choroid, which show up well with the ICTA here. And when you cut the OCT on the macula, that's why patients feel they have the blurry vision on the right eye. Because if you look at the outer segment carefully, they have something there in the outer segment part of the retina. And at the end, patient have the diagnosis of cryptococcal choroiditis. So we say not just patient vision, but patient life. Okay? Next one is the variety of uveitis management by biologic agent. As we know, most of the time people talking about using biologic for the posterior uveitis, hand uveitis, really bad diseases, but we now move to use it in some cases of anti-uveitis, like HLA-B27. We all know HLA-B27 is quite common cause of anti-uveitis worldwide. Okay, and look at this case. This case had the HLA-B27 cases, very hard to control, multiple recurrent steroid responder, super active lifestyle, and failed multiple conventional immunosuppressive therapy. And you see the IOP fluctuation. After we initial use of adalimumab with the TNF inhibitor there, you see how better patients are in terms of very good lifestyle, no progression, no active inflammation. So right now, this patient continues treatment with adalimumab every 6 weeks. So the biologic treatment is not specific only for the posterior or the hand uveitis, but it also works out well with some kind of anterior uveitis and together with the biologic treatment. Okay, and this is again see the IOP monitoring that we use at the biomarker. And when patients use it at home, the doctor can look through the app and see how the IOP go, and we can have the online discussion to manage without need the patient to come to the clinic as well. Okay, and this is how easy to use the adalimumab by themselves. You may say this is might be pricey and this is might be not cost effective. But let's say in Thailand, the cost of the biosimilar is much less compared to the original one. So when we do the cost analysis, the adalimumab using is almost equivalent to the cell step of mycophenolate. So we might have to talk with the patient about the option as well. Okay? And the biologic is not just biologic. We have so many more than TNF inhibitor. We have interleukin-6 therapy, which is promising. The socilizumab is promising in the treatment of uveitis. The abatacept is very good well with the uveitic macular edema, and rituximab that we always use for some specific case of CD20, such as the for the type of not C cells, B cell lymphoma, not C cell, B cell lymphoma. Okay? But when we use this kind of thing, we really have to aware one thing. Because in the TNF inhibitor, it can reactivate tuberculosis. Okay? So thinking about infection first. Okay, steroid sparing strategy, don't too much afraid to the immunosuppressive therapy. Okay. Okay, last but not least, we still have another option, which is the surgical management in uveitis. Nowadays, we have very good visualization. We have the small gate vitrectomy that can help us to unveil a lot of unknown things. I have one simple case here. This is a 16-year-old Thai boy, redness and burn vision for 2 weeks. If you look at the VA 200, and with 3-part vision test, the lens is quite clear, right? And unilateral posterior uveitis, when we don't know the cause. In the children, if you have the only unilateral, it's unlikely to be the most common uveitis with the JAA, which is common in the anti as well. We really need to think about the infection, but the workup come back negative. So what we should do? We have another option of the surgical vitrectomy, which is both diagnostic and therapeutic in this case. And you see the lens is here. Can you guess which one is it? What is the cause? You see some white lesion there. I don't know what it is. When we cut, you're gonna see how edge of the vitreous. And remember, this is 16-year-old boy. This is the vitreous is very heavy. You barely see the disc there. And right now you see there is some white part underneath on the fovea at the macular area. This looks like macular cataract, isn't it? But you see patient have the lens in the front. So it's not the macular cataract. So what is it there? Actually, same. We don't know what it is, but we take the way, we do the OCT there, we see, oh, that is it's like the hypopyon underneath the ILM. It's the sub-ILM hypopyon. You see it there? And you see the layer of the hyperreflectivity, not underneath the retina, but overline the retina, and have the ILM overlay. I try to check it, and you see its movement inside the lesion. Okay? So what we designed to remove the hypopyon with the soft tip cannula, and you see how it's like. Or the white cell come out, we try to remove the IOM there. Here, you see that? Can you see something? The cause of the uveitis there? Can you see the white line there? Not really, right? After we remove it, you see they have a lot of like cells. So we can use not just for the suction, but we also use the extrusion to clear the white cell at the fovea and remove it. Right now, we find the cause here. And if you look at the OCT, it's the intraretinal keratinocyte, not subretinal keratinocyte. So in that time, we decide to leave it or we should do something. With the OCT, we know we don't want to remove it because it's not separate, it's intraretinal. Should we leave it there or we do something? So at the end, I decided to do the laser just to make sure that it died properly in the retina and don't move away. Okay? And this is how come the surgical help in terms of management of uveitis. And we also have the emerging therapy coming to our field, like the stem cell therapy and nanoparticle therapy, photobiomodulator, and the JAK, JAK inhibitor, which is target JAK stat, which is promising uveitic treatment in the future. And that is my talk on the management of the uveitis.